to have one volunteers from you guys, okay? So who wants to volunteer to answer the first scenario? Anyone? Anyone?
Yes, ma'am.
Who's this?
This is Mamta, Dr. Mamta. Shall I read out the
Dr.
case,
Mamta?
ma'am?
Yes, go ahead.
Yeah, she's a pregnant 24 weeks and she's got painful genital lesions. History of same lesion treated 1 year ago.
So this is recurrent or primary?
So this is a recurrent. So we'll treat her with the standard dose of 400 milligrams 3 times a day for 5 days. And then we will give her a suppressive dose of 400 milligrams 3 times a day for 5 days from 36 week onwards up to term. And
Very
because
good.
she's a recurrent one, we can offer her vaginal delivery because it's a recurrent one.
Very
and it was not after 34 weeks, it was before. So we can offer her a vaginal delivery.
Very good. Okay, thank you.
Thank you, ma'am.
Another volunteer? That is clear, reassure, because this is a recurrent infection and the infection occurs in the second trimester also. Acyclovir 435, suppressive therapy at 36 weeks, and spontaneous vaginal delivery. Another volunteer, please. Another volunteer. Oh, you want to skip? I'll skip.
I want to volunteer.
Okay. Who's this?
Dr. Rabia.
Who's this?
Dr. Rabia.
Dr. Rabia, okay, go. Yes, Dr. Rabia, go ahead.
Okay, case 2, pregnant, 24 weeks plus painful genital lesions and no history of previous infection. So this is a case of primary genital herpes. I will immediately want to give her treatment with acyclovir, 400 milligram 3 times a day for 5 days. 400 milligram 3 times a day. Depending on if it's first or second trimester or third trimester. If it's first or second trimester.
So what is this trimester?
Okay, so this trimester is second trimester. So I'll give her the 435 regimen, and then at 36 weeks, I'm going to give her a suppressive regimen again from 36 weeks. Yes.
Okay.
Yes, then I can offer her vaginal delivery.
Okay. Thank you. Very good. So I have to tell you, okay, I just have one correction, okay? The dose doesn't change because I heard you said it depends if it is the first trimester or the second trimester. The dose is fixed. Acyclovir 435, okay, first, second, or third trimester, even the suppressive therapy is still the same, okay? The only difference is you stop it and then you don't stop it, okay? The dose remains the same for all trimester, okay? Thank you, Dr. Rabia.
Okay, ma'am. Thank you.
Another volunteer? Hello. Another one? Yes. Hi. Who's this?
Kiran Nas. Kiran Nas.
Okay.
Can you hear me?
Yes, I can hear you.
Pregnant 34 weeks plus painful genital lesion, no history of previous infection. So we will give her acyclovir 400 milligrams.
Doctor, just tell me if it is. Just tell me first if it's primary or recurrent, and what trimester.
It's primary.
Okay. So this is third trimester. Okay, and this is within 6 weeks, right?
Yes.
Okay, so what is
We
your
will continue a
management?
cyclovir 400 milligram until delivery, or we will recommend C-section
Very good.
because it is within 6 weeks or 36 weeks.
Very good. Oh, just give me 1 second because I can see some. Yes, acyclovir is safe in pregnancy. Dr. Timir, primary and recurrent herpes, which week we will stop acyclovir? Dr. Timir, primary and recurrent herpes, you only give for 5 days, okay? And then you resume at 36 weeks. HP, who is HP? Okay, I already answered your question. Okay, who else would like to volunteer for the next case? HP, who is HP? How do we diagnose herpes? I mentioned to you, you can diagnose herpes by 4 types, okay? Identification of the lesion, swab, nucleic acid amplification test, or your viral culture. Okay, who would like to volunteer for case number 4?
I can, Majida Razak.
Okay, go ahead.
Yes, the pregnant woman, 36 week with painful genital lesions plus no history of previous infection instead of having a vaginal delivery. Okay, so in this scenario, we are going to give her that acyclovir 400, but in this one is like offer her for the C-section. And if he wants vaginal delivery, so in that case, we are going to give the mother and the baby acyclovir, and we inform the neonatologist. Am I right?
Very good. Yes, you're right. Very good. Thank you.
You are.
So explain the risk. Give acyclovir IV, okay, until delivery because this is already 36 weeks, and inform the neonatal service. Okay. Next case, who would like to volunteer? Go ahead, guys.
I think in this case, I can read or someone else.
Okay, go ahead. Yeah, go ahead because no one's volunteering. You can.
Yeah, patient 38 weeks with a recurrent herpes on suppressive treatment plus came in labor without
on examination.
Yeah, on examination, you note that there is active genital lesions. So in this case, it's like she already have previously and she is on suppressive, so we can continue with the vaginal delivery. Plus, we can, we give the patient, mother and baby, again same IV cyclovir and inform the neonatologist.
Why do we give IV acyclovir? This is recurrent.
No. We don't give the IV cyclovir because patient already on the medicine.
Okay. We only give IV acyclovir if it is a primary and she insisted on vaginal delivery, even if you recommended cesarean section. Okay.
Okay, so in that is IV only we offer when patient have the primary infection.
Yes. The IV only is given if you recommend cesarean section and the patient insisted on vaginal delivery. Okay. Because the risk is very, very high. Okay?
Yes, ma'am.
So, guys, these 5 scenarios are clear, okay? Because one or two of these scenarios will come out in the exam. Okay? So that is why it is very, very important for you to remember to know by heart the algorithm. Okay? So can I proceed now? Any questions? Clear?
Yes.
Okay. Dr. Kiran, IV doses for the neonates 20 milligrams per kilogram every 8 hours. Okay, so this is the result. This is the complication of your herpes, okay? The neonatal herpes, okay? This is how it presents, okay? So you have to remember that neonatal herpes is 50% could be due to HSV1, so it's 50-50, okay? It's equally divided between HSV1 and HSV2. And for infants with symptoms, you have to remember this because this came out in the previous exam. 30% is localized to the skin. So if you can see my slides, I always highlighted in blue that one that is important, okay? So as we go on, I will tell you which come out in the exam, which is good to know, which is you have to know by heart, okay? So 30% is localized to skin, eye, or mouth. 70% is disseminated or CNS, and 60% is a combination of both, okay? 30, 60, 70. So this is the reason why we recommend cesarean section for primary, because the transmission, the maternal to child transmission is 41%. But for recurrent, it is only 0 to 3. That's why we recommend vaginal delivery. If the infection is within 6 weeks, that is 34 weeks, the delivery should be by cesarean section, and the risk is higher if there is rupture of membrane more than 4 hours. So, and it's also advisable not to use fetal scalp electrode or artificial rupture of membrane if patient has herpes infection. Okay? No AR open. So this is another complication of your herpes, which is your erythema multiforme. Okay? It presents like this, okay? Like a bullseye lesion, target bullseye lesion, like this. Okay, see a central blister, an edematous ring, and an erythematous border. Okay, so this target bullseye lesion you cannot only see in herpes. There's also one disease that is the target bullseye lesion is pathognomonic, which is your Lyme's disease. Okay, the Lyme's disease also presents with this target bullseye lesion. Okay. Sometimes you can see here maculopapular rash. Sorry. Okay, maculopapular rash like this. So you can still see the target lesion, right? And you can see here the extensive oral lesions, desquamating lesions, or what you call your Steven-Johnson syndrome. The patient at risk of developing erythema multiforme are the ones taking and the ones with mycoplasma, pneumonia. Okay. Okay, any questions about herpes? We will go with chickenpox now, varicella zoster. So herpes 1 and 2 is clear to you guys.
Yeah, ma'am, one doubt just. You said that at 28 weeks, if a patient develops herpes, we continue it till term and then we recommend cesarean, or we recommend normal delivery if they've been having herpes from 28 weeks, because after 34 weeks anyway we do C-section. From 28 we start continuous, and for that patient we can advise normal delivery.
No. Primary genital lesion in the third trimester, you always recommend cesarean section,
Okay.
especially if it is within 6 weeks. Okay.
Okay. And then another thing you said, at delivery, if there is genital lesions, and if it's a primary one, if it's a recurrent one, we can deliver spontaneously also. If it's a primary one, ma'am, what should we do?
It's a primary, so you recommend cesarean section.
Cesarean. With the IV, this thing, we are seeing her for the first time, so we will give her IV acyclovir, right?
IV if she insists on vaginal delivery.
Okay. If it's cesarean, no.
Okay.
No need.
No.
For only the oral one, then we can do.
Yes.
Okay, ma'am, thank you.
Okay. So now let's go to chickenpox or your varicella zoster virus. You all know, I know once in your lifetime, you had chickenpox, okay? Or maybe you cannot remember because you had it when you were a child. So most of us are already immune with the varicella zoster. Okay, so this is how the lesion looks like. Okay, there are different stages of the lesion. Some are vesicular, some are just small lesions without fluid. So these are the different stages of the lesion. Okay, so varicella zoster virus or your human herpes virus 3, the incidence is 3 in 1,000. It is highly contagious and the mode of transmission is respiratory droplet. Okay? So if in herpes, what I told you is you have to know whether it is a primary or a recurrent infection. In varicella zoster, what is important is significant exposure. What do you mean by significant exposure? When you say significant exposure, you are with an infected person 15 minutes in the same room, or you have been talking to an infected person 5 minutes face to face. So this is your significant exposure. That means if you're only talking to that person 1 minute, that is not significant exposure. If you are only in the same room 10 minutes, that is not significant exposure. So it should be within this time frame, 15 minutes and 5 minutes, for you to have to say that there's a significant exposure. Why? Because when there is significant exposure, we give a certain treatment. Okay? So incubation period, 1 to 3 weeks or 7 to 21 days. So sometimes they ask by weeks, sometimes they ask by days. So you have to remember that it is 1 to 3 weeks or 7 to 21 days. And the period of infectivity is 48 hours before the rash appears until the vesicle crust over. The vesicle crust over for 3 days, so it's a total of 5 days. So 5 days, okay? The secondary infection, it's called herpes zoster, right? Or your shingles. So your herpes zoster, this is This is your herpes zoster, okay? This is dermatomal, okay? That means only occupies a certain portion of your body, and it is most common in the thoracolumbar region. And it is very, very painful, okay? More painful than your varicella zoster. Okay? So remember, the complications of your chickenpox, pneumonitis, 5%, encephalitis, hepatitis, and death. Pneumonitis, okay? Previous exam question, 5%. So why I asked you to remember acyclovir 435 for herpes? Because for varicella, acyclovir is 857. That means 800 milligrams, 5 times a day for 7 days. So how will you remember in the exam? Because you know that herpes is acyclovir and varicella is acyclovir. So during the pressure of the exam, you don't know whether it is 435 or 857. So always remember, herpes, the word herpes is shorter than the word varicella. So for herpes, everything is short. Okay, less grams, shorter interval, and shorter duration. Varicella, it's a longer word. So you give more grams, more frequent, and longer duration. Okay, so just remember that. For herpes, it's a shorter word, so it's the 435. And varicella is 800 milligrams, 5 times a day for 7 days. Okay? So this is your fetal varicella syndrome. Okay, fetal varicella syndrome. So we have 2 types of infection. Like the neonatal herpes, for varicella, you have 2 types. You have your FVS and your neonatal varicella syndrome. Your fetal varicella syndrome, usually you get it in the first 20 weeks. Some books, it says 16 weeks. So don't be confused if it says 16 or 20, it's the same, okay? So you get fetal varicella syndrome in the first 16 to 20 weeks of gestation. The overall rate of infection is very little, only 1%. Okay, you can see here the fetal-maternal transmission. 1 to 12 weeks, 0 to 4, 13 to 20 weeks, 2%. Overall is 1%. Okay. So the fetal varicella syndrome you get from 16 to 20 weeks. No, this is not percentage. Sorry. This is age of gestation. Okay? You get by 16 to 20 weeks age of gestation, and your neonatal varicella syndrome, you get it within 10 days of delivery. That means 10 days before and 10 days after delivery. Okay? So another complication is your Reye syndrome. So what is Reye syndrome? So this is your Reye syndrome. Reye syndrome is caused by your varicella and your influenza A or B. So what happens if you are a patient, okay, taking salicylate, it gives you risk factor for Reye syndrome. So what is Reye syndrome? This is progressive encephalopathy with hepatic dysfunction. That means after a flu infection, after you get a flu infection, or after you get varicella infection, you becomes delusional or you becomes confused, and then you have hepatitis or any hepatic dysfunction. This is what you call Reye syndrome. And Reye syndrome is only caused by your varicella and your influenza A or B. Okay? So what is there to remember for all the viruses and the bacterial infection, especially for the DNA viruses? You have to know what congenital anomaly they cause. Okay, so for herpes, you have neonatal herpes, and the effect on the baby is what? The 30, 60, and 70. There's a lesion in the eyes and the mouth, a lesion in the CNS disseminated, and or both. Okay, so that's for your herpes. For the fetal varicella syndrome, okay, I give you another tip. For all those viruses, you have to remember what is specific for that virus. You don't have to memorize microcephaly. All of them, believe me, all of them causes microcephaly. All of them causes retinitis. Okay? So when you are in the process of elimination during the exam, you pick up the one that is specific for that particular virus. For example, for varicella, you will only see limb hypoplasia and cicatricial scarring in varicella. This is very, very specific for your chickenpox. So in the exam, if you see microcephaly or your retinitis, cataracts, okay, mental retardation also, you can see it in all other infections. And limb hypoplasia, so you can immediately tell, or you can immediately pick up that limb hypoplasia and cicatricial scarring is specific for your chickenpox. So when you say limb hypoplasia, the limb is shorter, okay, and this is what you call your cicatricial scarring. Okay, you can see this is the normal leg, and this is the other leg that is affected. Okay. Okay, another algorithm. So I mentioned a while ago that for herpes and varicella, the college is very, very fond of giving scenarios. So again, I want 100% of your attention for this algorithm. Okay? So I told you, clarify significance of contact. So what is significant exposure? 15 minutes within the same room and 5 minutes face-to-face. Okay? So first scenario, there's a past history of chickenpox. Okay? She already has a past history of chickenpox. So if she is immune, then there's no action needed. You only have to reassure and normal antenatal care. Okay? Second scenario, okay, the patient is uncertain. She doesn't know if she has chickenpox before or if she came from a tropical or subtropical country. So you have to know what are the tropical and subtropical countries. Asia, Caribbean, okay? So if she is uncertain for the second scenario, what you have to do is check the blood for varicella zoster virus immunoglobulin G. Not M, okay? It's G. Because the G, as you all know, it means what? Previous infection, that means immunity. Okay. If the IgG is present, then you go to here, reassurance, no action needed. If the varicella zoster IgG is absent or negative, okay, So what you will do is you have to give varicella zoster immunoglobulin. Okay? So positive exposure, significant exposure, you give VCIG if negative for immunoglobulin. Okay? So that means you can give your VCIG within 72 hours or until 10 days. So you can give the immunoglobulin until 10 days for exposure. Okay? So third scenario, the patient presents with the chickenpox rash. That means you see a rash. Okay? So what you will do, if there is a rash, you give your acyclovir 857. Okay? If it is severe infection, that's the only time you give intravenous. Okay? So if she has exposure, you give immunoglobulin. She still develop chickenpox, then you go to this, okay? You still give her acyclovir, okay? And acyclovir, if you give the first dose, you can repeat another dose after 3 weeks. If she has another exposure, okay? So that means if she is exposed today and then she's exposed next week, you don't have to give acyclovir next week. You don't have to give acyclovir after 2 weeks. You only give acyclovir after 3 weeks from the last dose. Okay? Is this scenario clear? Is this algorithm clear? We will go to scenarios in the next page, and I need another volunteer here. Any questions in the algorithm?
Yes,
Remember?
repeat the 3-week dose.
The same dose.
Repeat again. What did you mean by 3 weeks?
3 weeks. If you get acyclovir today, if you get not acyclovir, immunoglobulin. Okay, if you get immunoglobulin today because you are exposed, you don't have to get it. You don't have to get another dose within 3 weeks. If you get exposed after 3 weeks, then you can get again another dose.
Oh,
Clear? Okay.
Excuse me, ma'am.
Yes.
In this 3-week period, is that just for the immunoglobulin and we are not talking about acyclovir, right?
No, that's for immunoglobulin only.
All right, okay. Thank you.
Okay. Welcome. So remember, for herpes management, okay, you have to know whether it's primary or recurrent. Okay. And for primary and for chickenpox. So remember the dose for 35857. And you give the medication within 5 days, and for acyclovir within 24 hours. Okay, so that means after 24 hours, your acyclovir is no longer effective. Okay? Okay, let's go with the scenario. Any volunteer?
Yes, ma'am.
Okay, go ahead. One by one, okay? Go ahead.
Okay, so
This is a pregnant 28 weeks. She is a teacher and she is exposed to her student with chickenpox. She said she has history of chickenpox when she was a child. So because she is clearly stating that she has history of chickenpox when she was a child, she can be just reassured and continue with a normal antenatal care.
Okay. Okay, next. The other doctor?
yes, ma'am.
Okay, go ahead. I'm so sorry because I cannot see the one who's talking. In my screen, I cannot see who's talking. Okay? So I cannot call you by name. Okay, go ahead.
The same scenario, I think.
It is the same scenario, ma'am.
Go ahead.
Yes. So, a pregnant 30 weeks plus her toddler has chickenpox rash appeared 2 days ago. Plus, she is not sure of having chickenpox as a child. So, ma'am, in this scenario, since she is saying that she is not sure of having the chickenpox as a child or not, and the exposure is obviously significant, so we will do the IgG test on her bloods, and then we'll see for the results. So, if the result is positive, that means she has had chickenpox. So, again, we'll just reassure her, and nothing needs to be done. But if she doesn't have the IgG in her blood, then we will offer her Varicella zoster virus immunoglobulin.
Okay. Very good. Another volunteer.
This is Majida Razak. So, the pregnant.
Who's next?
Majida.
Majida, okay, go ahead.
Yes, pregnant woman, 32 weeks, non-immune, plus her toddler has the chickenpox. So she received is a Varicella zoster immunoglobulin. After 2 weeks, she got in contact with her cousin with chickenpox. Okay, so in this scenario, we are going to, she already we give the immunoglobulin, so we don't need to do anything till the after 5 weeks. We're gonna give her second dose to her. So right now we just
5 weeks.
I'm sorry? Oh, 3 weeks.
5
yes.
weeks. Okay, 3 weeks, not 5 weeks. Okay.
Yeah, 3 weeks.
Very good. Okay, another volunteer. Another one, so that we can proceed.
Ma'am, can I go for it?
Okay, go ahead.
So, pregnant 34 weeks plus teacher came into the emergency department with chickenpox rash. She said she had a student with chickenpox rash, and this morning she noted the rash appeared on her abdomen. So, since she is already showing the rash, so we will give her the acyclovir 857, 800 milligram 5 times a day for 7 days.
Okay, very good, thank you.